Hi everyone, my name is Matthew Mark and I'm one of the stroke doctors over at Dominican. Um, my job today is to try to make your job easier, and in particular the job of making my job easier when it comes to stroke patients. So we're working on how to save time. Time is brain. For one reason or another, the brain's not getting enough oxygen, and that's what a stroke is. So the way to save brain is to save time. Everybody knows stroke's an emergency. Everybody knows what to do when they actually have a stroke. I certainly, if you put a stroke patient in front of me, I know exactly what to do. The challenge, I think this is especially a challenge for the emergency room docs, because I'm not always in the emergency room. They call me when they have a stroke. But the challenge is they don't always know when to call me. And they don't call me for everything, and they shouldn't. The challenge is we always have people coming in that think they might be having a stroke, or I think it could be this, and whatever. The challenge is, how do we find the ones that are either complicated and they can't tell and they need me to help them figure it out, or the ones they definitely know is a stroke and they need everything to be happening immediately. So a common thing is they're handling some other emergency. And then someone comes in and says something to them. And that thing could be, we've got a patient in triage, they think they're having a stroke. That's option one. Option two is 66-year-old male, fast eval says stroke, last known normal 45 minutes ago, acute onset, speech, face, arm, leg, weakness. Blood pressure is 185 over 110. Blood sugars are normal. We've placed an 18 gauge, ETA 15 minutes. That is definitely going to get them moving differently than the first one. And they could be the exact same patient. So the pre-hospital care really affects us a lot. Look, whether you use FAST or BFAST or New FAST, whether you use the Cincinnati pre-hospital stroke scale or the LA pre-hospital stroke scale, I promise you no one cares. What we care is that you understand what scale you use, that you use a scale well, that you use it the same way every time, for you anyway, so that you have your own personal method of doing it, that you understand why you're doing what you're doing, and how to communicate that effectively. As long as that happens, we're going to do great, and you're going to get good people to us. And we really, really rely on pre-hospital care, and all the studies have shown that once you reach a certain point in stroke management, there's nothing more I can do. I can get someone to the CT 5 minutes faster or something like that. I can do little bits, but it's not going to matter nearly as much as the pre-hospital care, the pre-hospital evaluation, and then any other things that you can do in advance to make sure. The difference between having an 18 gauge IV placed in the field and having one placed once I'm on the CT scanner is huge. I've got to get them off the scanner. I got to get a nurse. I got to get them back into the other room. It just, all that time adds up, and time is brain. So first things first, when it might be a stroke. When did it happen? A lot of these are wake up symptoms. So last known normal was not last night at like 9 o'clock or something. But a lot of times the wake up symptoms that I see, it still happened pretty recently. Now this might rule out whether I can do a clot busting drug, TPA. But it won't rule out whether I can use what's really our best tool, which is clot retrieval, also known as thrombectomy. That can be done 6 to 24 hours after a stroke, depending on the degree of damage that's occurred so far. So every minute counts. Find out if there's other conditions. Is their blood sugar normal? And does anybody think they've had a seizure? So ask somebody nearby, or ask if they have a history of epilepsy or have ever had a seizure before. The reason for this is because hyperglycemic coma with associated paralysis, or paralysis after a seizure, looks exactly the same way as a stroke. Post-ictal paralysis is facial droop, arm weakness, leg weakness. They're just hemiplegic. It looks exactly like a stroke. If we can avoid giving TPA to somebody who had a seizure, I'd prefer to. Now, both can happen, but just I'll make the decision. But if you can find that out, or if you find out if they have a history of epilepsy, that would be helpful. One set of questions. What's their blood pressure? This is important because I can't give TPA unless the blood pressure is below 185, and the difference between me having atenolol or diltiazem ready or having to go get it is it's 5 minutes of brain or more. Are they currently on anticoagulation? Are they on a blood thinner? Especially, are they supposed to be on a blood thinner, and was it stopped? Again, this helps me a lot. Someone who is probably blind on one side, but I can't really tell because they're sort of vomiting and dizzy, whatever, but they're in AFib and they stopped their anticoagulation 4 days ago for a knee replacement tomorrow, is a different kind of patient than someone who's just kind of feverish and sick or whatever. It helps me understand how quickly to move, and it helps increase our score and our pretest probability. So the big MCA strokes, the big middle cerebral artery strokes, the ones that are going to be easier to see. You'll know when you see them. Numbness, weakness, facial droop, loss of speech, or nonsensical speech. About a third of cases are posterior circulation strokes from the vertebral arteries, or the arteries dealing with the back of the brain. Those are a little bit harder. Those are quite a bit harder. You might also have some of those other symptoms, but usually it's going to be more balance, unstable gait or unstable gaze, and then inarticulate speech or swallowing problems, nausea. They'll say they're dizzy, maybe numbness with just one side of their body, but not so much weakness. These are some of the more common syndromes. It's probably not relevant to go through all of the details of those, but I would say this. It's very common to have someone who's unbalanced for any number of 100 reasons. But what you're looking for is if that balance is to one side. So drift is a good way. You have them put their arms out like this, and you close their eyes, and one goes like this, or one will go like this. Another thing you can do is you can finger, nose, finger. Finger, nose. You move it to the side, goes back and forth. You'll notice when I do this, I'm not dropping down, going like that. I say, I'm holding my finger out in front of you. Imagine there is a string connecting your nose to my finger. Run your finger along it. And then on the other side, they go like this. All right? That is asymmetric. Another challenge is when they're looking with their eyes and they're following something around. If their gaze is nystagmatic. Here's a challenge. Drunk people. Drunk people have strokes too. But drunk people that are imbalanced aren't imbalanced on only one side. Likewise, if you're having a stroke and it's of a particular part of the brain, your eyes are going to be jiggling at neutral gaze. So if you have them look at just one thing, look just at me, look just at my finger, and they're going back and forth with their eyes, that's not a good sign. A drunk person is going to have loss of smooth pursuit, but a stroke patient might have loss of smooth pursuit only in one direction. So they'll go like this, and they'll go dook, 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 dook when they go the other way. It's subtle. I'm not really hoping that you can find this, but if you're just happen to be doing it, that's something that you can look for. Also, dysarthria. So a person can speak inarticulately. Their head seems to be screwed on straight. They're not confused. They're not going, I was before to have, then I went to find, go. That's aphasia. This is, no, I'm in Santa Cruz. I'm Santa Cruz. And it just, they are physically incapable of producing articulate speech. You say ba ba, and they can't do it. That's a sign of a posterior circulation stroke, probably more likely than the anterior circulations. You're probably not going to be walking them. And then last is nausea, like unexplained nausea. So the person who has a posterior circulation stroke that's causing nausea is almost always going to have other problems too. So I don't want you thinking anybody who's got nausea might be having a post-circ stroke. No. But someone who's having nausea from post-circ stroke is having it because they're so dizzy, the whole world is spinning, nothing can stop. So you have them close their eyes, and then when they open them, their eyes are going do 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 do. So that's probably the cause of their nausea. That's when you might asking yourself, okay, are their blood pressures high? Are they smoking 2 packs a day? Are they off anticoagulation recently? Now you're going, oh, this person's a high stroke risk factor person. They've had a stroke before. That's the number one risk factor for stroke, is he had a stroke before. That's when you start to go, okay, this person's nauseous and dizzy. Maybe they're having a stroke because they're high risk factor. So that's you're gonna have a real challenge diagnosing a posterior circulation stroke in the field. But what you might be able to do is you might be able to deliver a patient who otherwise might have been just run-of-the-mill nausea, maybe he ate something bad, maybe he's drunk, whatever, and say, but he had maybe some focal findings, and he's off anticoagulation, in AFib, with a smoker, and he's had a stroke before, so he's also a high-risk stroke patient. Just that little thing just throws something else to the emergency room doc to kind of go, maybe this isn't somebody I should sit on for a minute until he stops vomiting. Maybe I should just do some basics or call the neurologist just in case. And that's probably the best we can do with something. Those are tough cases. So last, just to restate what I think is good information to provide en route. What we're listening for is when you think this is a high-risk stroke patient. Whatever you're doing for the patients that are this, could be this, that's probably fine. I think if we focused for now, for me, on the ones that we think are slam dunks, really good stroke patients, is how can we maximize them? What we're listening for is, I think this is a high-risk stroke patient because fast pre-hospital score, etc. Their blood pressure is X over Y. Any other important information you think we need to know. Last known normal time was, we will place an IV, our ETA is X number of minutes, should we take him to CT scanner or not? That one said sentence, I think will help a lot, and it will help kind of activate the type of things for the peri-hospital care that I think makes a difference. Thanks a lot.